Hi everyone, thank you for joining us today. I'm Bryce Smith with Carson Kids. Today we'll be going over practice essentials, ethics, research, and activity analysis. The content for this lecture primarily comes from AOTA's NBCOT test review, Therapy Ed, and the NBCOT website itself. Before we begin studying, I always like to take a mindfulness approach. This will help to reduce your anxiety when you go to take the test. Let's begin with 3 deep breaths. And one last deep breath. Now you can repeat your favorite mantra or do a visualization. For me, I like to say and also write down my mantra. One of my favorites when I'm studying is that I will receive and retain the information with ease. So now I'm going to repeat that mantra. I will receive and retain the information with ease. Now I'm going to write it down. I will receive and retain the information with ease. When you're ready, let's begin. Let's begin with our practice essentials. You do need to know your OTPF going into the NBCOT exam. I know you heard me say it many times on the first lecture for tips and tricks for the NBCOT. But the NBCOT is a legal examination, and the OTPF is our legal document. You need to know the terms and their definitions. We should know that occupations are everyday personalized activities that people do as individuals, in families, and with communities to occupy time and bring meaning and purpose to life. We need to know that contexts are environments plus personal factors. So contexts go beyond the environment to have that extra layer of understanding and meaning and purpose. We have performance patterns, which are habits, routines, roles, and rituals. We have performance skills, which are observable goal-directed actions that result in a client's quality of performing desired occupations. And client factors, which are specific capacities, characteristics, or beliefs. And again, this all comes from the OTPF. Really, it's good to take your time with that document, read it, write down those terms, write down those definitions so that you know them. A lot of us are familiar with the OT process of evaluation, intervention, and outcomes. What becomes important on the NBCOT is recognizing where you are in the OT process to correctly answer questions. So sometimes you might be in the intervention portion, and they might ask you what the next best step is, but some of the choices might be more for evaluation and assessment. So you do really want to understand where you are at in the OT process when you are answering your questions. Let's look at some more definitions. We have our ADLs and our IADLs, and again, you're going to want to know the difference. You might have a question about, what is best for an ADL, and you might have some choices that are IADLs. You should know the difference so that you can help get to the right answer. So for ADLs, some people like to use the term B deaths just to help them remember the different categories. So the B is obviously for bathing. Then we have dressing, eating. The A is for ambulation rather than functional mobility. And again, I think it's just to make it into a word. Then you have toileting, hygiene, and sex. If you have your ADL list really well known, it's a little bit easier to determine what's in IADL. Sometimes IADLs are a little bit easier for us to know because they are involving an instrument. But whatever method works best for you for memorizing these lists. Let's continue with our OTPF theme. Now, there are sometimes people like to think about it as like this little nesting egg how something is large, and then within it we have another definition, and within that we have another definition. So I do like to think about this next section almost like an umbrella. So we start with activities, that largest egg. These are actions to support the development of performance skills and performance patterns. Now let's go a step further. Performance skills are observable, goal-directed actions. Performance patterns are habits, routines, roles, and rituals. Now within performance patterns, we have some more definitions. So again, we're opening that egg, we're going a little deeper. We have habits, which are specific automatic behaviors performed repeatedly. We have routines, which are patterns of behavior. Roles, which are sets of behaviors expected by society or culture. And rituals, which are sets of symbolic actions with spiritual, cultural, or social meaning. So again, when I'm studying this, I like to write my actions, then I have performance skills, performance patterns, and then below performance patterns, I have those habits, routines, roles, and rituals. It makes it a little bit easier to see how all those terms come together. Now again, we have client factors, which are values, beliefs, spirituality, body functions, and body structures, which is again, another one of our umbrella terms that we can then break down. For practice essentials, we also want to think about documentation. You will probably get a few questions about documentation on your exam. First, we want to make sure our documentation proves medical necessity, and that means that the client medically needs these services and that we are providing those skilled services to them. There are orders which come from physicians to refer for OT. We have screenings which identify if a person may benefit from OT. So a screening is not an eval, it's the step before. It's like an OT going into a classroom of students and seeing if any might need OT evaluation and services, right? Going into the community to see if anyone might benefit from OT eval and services. It's the step before the eval. And then we have the evaluation itself. It's typically done by an OT, but parts can be done by a COTA if they are considered competent in it. So example, if you have a COTA who's competent in the P-body or range of motion testing, they could do those portions of the eval. For intervention, that could be done by the OT or COTA. And for re-eval and discharge, again, the same thing. Parts of it can be done by the COTA if they're competent in it. So if they did the P-body for the initial eval, they might do the P-body for the re-eval. And that's totally normal and okay for supervision as long as, again, that COTA has been deemed competent with that part of the assessment. Now I do have highlighted collaboration. The OT exam loves for us to collaborate with others, collaborate with PT, collaborate with speech, collaborate with the client and their family. They really want that well-rounded, holistic perspective going into the eval, intervention, and discharge planning. So if there's an answer that's leaning towards collaboration, that's probably the correct one. Just as a hint. Going into some documentation details. I know a lot of you are familiar with SOAP notes if you haven't done it in a while because you've done EMR. Just a reminder that SOAP notes are subjective, objective, assessment, and plan. So again, that subjective is usually like a quote from the client. The objective is what happened without any interpretation. The assessment has your professional interpretation, and then the plan is what's coming up. We have burp, perp, and SERP, which are less common on the exam, but I do just want to give this information to you in case you get a random question about it. So the ERP part that is consistent stands for intervention, response, and plan. This is really useful for mental health because SOAP notes can be tricky to write for mental health. So instead, we're going to detail the intervention, the response, and the plan. Now for those different first letters, we have behavior, purpose, or situation. I wouldn't really worry about memorizing these so much. Again, I would just focus on that last part that's consistent through them all. So like the intervention, the response, the plan. Know that burp, perp, and SERP, those weird ones, are for mental health. We have transition plans which support the client going from one service setting to another and include our recommendations. For our goals, we have COAST, which is our client, occupation, assistance level, specific conditions, and timeline. You'll also want to know the difference between DME and adaptive equipment. So durable medical equipment is reusable. We're thinking about walkers, hospital beds. Adaptive equipment is everything else. So that's reachers, tub seats, grab bars. And you just want to know the difference because, again, a question might ask you, what is the recommended DME for this client? And you don't want to pick an adaptive equipment piece, right? So they try to give you these clues if you know the definitions really well. There is some setting-specific documentation that you should know. Early intervention must be related to the Individualized Family Services Plan. School-based must be related to the IEP, the Individualized Education Plan. For Medicare, there are a couple different requirements depending on the setting. We have a requirement for inpatient, for long-term hospitalization, for SNF, and for home health. I would just know what those are, especially the OASIS. That's really common to have a question about OASIS for home health for Medicare. And as always, we have our legal considerations. You should know HIPAA. You should know how we practice HIPAA and some things that we could do to maintain the requirements there. So if you're talking about a client or if you are doing some type of communication about the client, you should know your guidelines on HIPAA. And there are just so many, it's really hard for us to go through all of them. Obviously not talking about a client to someone who does not have access to that information, not going out in the community and sharing that information. Some of those are very obvious. Others are a little less so, so just really be mindful when you're answering questions that we are maintaining HIPAA. ADA prohibits discrimination, and we'll be going over parts of the ADA as we go through these lectures. IDEA provides early intervention, special education, and related services for kids. And then we have accreditation. Joint Commission is required. CARF International is optional. They probably won't ask specific questions about Joint Commission or CARF, but just know that they are accreditation bodies. Oversight. You are very likely to have a question or two on this. Just so you know, AOTA is voluntary. They can only handle complaints for OTs who are or were AOTA members at the time of misconduct. Each state has its own procedures. You're not going to be tested on that. You will probably get a couple questions about NBCOT's jurisdictions over OTs. Complaints are not anonymous. And there are sanctions that the NBCOT, it's essentially like punishments that they could decide. So you might have ineligibility for certification, a reprimand that's not publicly announced, a censure that is publicly announced, probation, supervision, or revocation, which is permanent loss of your certification. You made it through practice essentials. We're getting ready to head into ethics. Let's do some soothing movements, rolling our shoulder, maybe stretching our neck before we head into this next section. You will want to know the profession's core values because you might get a question on these. Altruism is the unselfish concern for others. Equality is being free of bias. Freedom is valuing the client's right to guide. Justice is respect for legal rights. Dignity is valuing inherent worth of each person. Truth is faithfulness to the facts. And prudence is rational thought and judgment. Following our core values, we have 6 ethical principles, which again, you are likely to get at least one question on. Beneficence is doing good, while non-maleficence is doing no harm. Autonomy is right of the client to self-determination. Justice is to promote equality and inclusion. Veracity is truth-telling, and fidelity is treating others respectfully. That ethics section was a little dense, That's okay. You can pause here, really work on physically writing those definitions, and then doing a couple related practice questions that will really help you to solidify that information in your mind. Before moving on to research, let's do some soothing movement again, our shoulder rolls, our neck stretches, and let's begin. Research is my personal favorite, so I'm going to try to stick to NBCOT related information only. We have our evidence pyramid here, and you can see how it gets higher in rigor the closer we get to the top. So at the very top, we have meta-analysis, which is the synthesis of randomized controlled trials. It's the highest level we have. Systematic reviews are just below it. We're combining all of that literature. We're combining those randomized controlled trials. When we're doing a meta-analysis, though, typically we're running more statistical analysis, so that's why it's a step above. We have randomized controlled trials, which is, again, randomly sorting into control or test groups, so there's a really low risk of bias. We do have cohort studies, which follows a group over time. The NBCOT likes to ask about cohort studies just because I think they're interesting. They're very related to OT. So again, following one group over time is a cohort study. A case control usually has like a natural control group where, again, you might have people with heart disease and people without. Like the natural control group is people without. Cross-sectional is one point in time. So if you're looking at the average cortisol level of students before taking the NBCOT, boom, that's one point in time. There's no pre and post, no other points. It might be like the average BMI of college students. It might be the average heart rate of OTs after performing an eval. Whatever it happens to be, it's just at one point in time. That is a cross-sectional study. Now, when you have a study that has all these different components in it, maybe they kind of mention that, oh, they're following this group over time, but they randomly sorted them into control or test groups. And they're asking you what level that study is or what it should be classified as. Do you want to pick the highest level that a study can be considered? So again, if it has components of, like a cohort we're following over time, but we randomized it and we have a control group, we want to choose that RCT instead. Whatever's the highest level it can be considered is what that study is defined as. So again, for research study types, we have quantitative, which include numbers. That cross-sectional is at one point in time. The cohort is one group over time looking for trends or outcomes. Case or case series is usually descriptive. It can be quantitative, qualitative, or mixed. So for a case study, we're just following that one person, maybe with a really unique diagnosis or a really unique treatment. A case series is like a couple different case studies all rolled into one, maybe like a small group with a really rare diagnosis or a small group who, got some kind of experimental treatment. For case control, we have quasi-experimental, which is case control but without randomization. Again, you're putting them into groups or they're naturally put into groups because someone either has a condition or doesn't. And RCT is case control with randomization. Qualitative is obviously more about words. We're not looking at numbers for that. And mixed methods has components of both. When we are interpreting quantitative findings, we might have a p-value. They really like p-value and r-values because they're the inverse of each other. So p-values, you either reject or accept the null. And the null is always like, there is no relationship. So you want to reject it. So there is no relationship between OT and outcomes, right? There is no relationship between sensory integration and sensory processing scores, right? So we want to be able to reject the null. Usually it's 0.05 or less, and that just shows that it wasn't from chance. So the smaller the number, the less risk that the results were just from chance and not from the true findings. For R value, it's different in the sense that the bigger number is better. So p-value we want to be small, R value we want to be high. So this is for correlation is R value. Correlation has a bunch of R's in it, R value. It can be -1 to 1. In 0, there is no correlation. Anything close to 0, like 0.2, is very weak. And I have this picture here at the bottom that helps to explain it. So you can see that first graph where the slope of the line is going up, that would be a regular 1. If it's decreasing in a nice straight line, that's -1. And then if it's just a flat line, or we can't even draw a line with the data, that's 0. So it's just showing that, like people who brush their teeth have, lower risk of heart disease. That's a really common one, right? It's correlation. They're not actually causing each other, but there's a positive relationship there. So it'd be +1. You're so close to the end. Let's just do, again, some of that soothing movement. Maybe we're rolling our shoulders forward this time. Let's stretch our neck a little bit. You're almost there. Activity analysis. We have activity demands, which are what is required. We have occupational demands, which are required of the specific client. So activity demands are more general. Occupation demands are for a specific client. Context, again, is that environment plus personal factors. We want to promote client performance. So we might do something like grading, either upgrading something or downgrading it. We might do fading, where the OT gradually provides less support. We might do chaining to teach individual steps. So forward chaining is going from start to finish. So, getting out your toothbrush, putting it under the faucet, putting on the toothpaste, putting it in your mouth. That's forward chaining. Backward chaining is doing finish to start. So maybe you do the prep the first time and the client puts the toothbrush in the mouth, and then the next time you get the toothbrush out, you put it under the faucet, and then they put on the toothpaste and then put it in their mouth. That's backward chaining, right? But like we're moving the client backwards through the activity to help them learn it or to rehab them through it. Adaptation is changing activity demands to match the client. And I think we're pretty familiar with that, and we're going to hit on it a little bit more in future lectures as well. You should know your frames of reference and what they need. You will probably get a few questions asking you to apply a specific frame of reference and choose the correct answer. So they don't often ask for a biomechanical approach, but what they'll say is using a bottom-up approach, which answer is best, right? And you need to choose that bottom-up answer. For cognitive behavioral, I know a lot of us think about it in the real world where it's typically used with pediatrics, and it's usually like this reward system, like, oh, you sit on the potty, you get an M&M. That's not how the NBCOT thinks about cognitive behavioral. They think about it from an OT perspective, which is thinking about the behavior, more of like that adult perspective where we are thinking about our behavior. So if they want you to apply CBT and you're looking through your answer choices, you need to select the one where we are thinking about the behavior. For ecology of human performance, this is the environment. You need to choose the answer that has something to do with the environment. If you are applying the ecology of human performance model, it's going to be the answer that has something to do with the environment. So ecology, environment, ecology, environment. I think we're all a little familiar with MOHO, how it's a lot about volition and motivation. So again, if you're applying MOHO, you need to be looking for that answer that has volition or motivation in it. Occupational adaptation is kind of obvious. Again, we're going to look for an answer that has some type of adaptation in it. They usually don't ask for like the PEO or the PEOP, but instead what they'll do is like a top-down approach. So they might say like bottom-up or top-down approach, and you should be looking for that answer that fits that frame of reference or model. I know that was really dense. Thank you for hanging tight with me. What I really recommend is that you go back through, physically handwrite your notes for this section. And what I like to do after I physically handwrite it is to type it. And then I use that typed version to review later on. But that really applies a lot of knowledge for you. While you're studying, don't forget your favorite essential oil to use and to keep your setting as close to the actual test date as possible. If you have any questions about this material, please feel free to reach out to us at carsoneKidsEDU@gmail.com, and I'll get back to you as soon as possible on those. Thank you.